When I think about effective cancer care, I think a lot about multidimensional care. We have things like tumor boards, we have physicians who are coordinating across specialties. Are there any gaps as far as who needs to be sitting at the table when it comes to providing comprehensive care that includes, psychiatric care? Is this a matter of getting people's family or community involved, or do we need an additional set of professionals or different types of counselors to really be involved to round this out? Can we do this with our current
The,
kind of?
the approach we've taken is kind of a public health approach. I could use an example that if you want to improve palliative care in the world, in most parts of the world, it will not be delivered by a specialist in palliative care. So we need to train primary care providers in providing palliative care. The same thing is about psychological care. So we're involved now globally in training people who are in cancer centers, people who are talking to patients in how to provide this kind of psychological care. And CON provides a vehicle to do that. What we've shown is a relatively brief therapy actually can be very powerful and very effective at this moment in time. Patients are distressed but highly motivated to receive this kind of care.
And is there room for, I think of the importance of more structured, at least in the US, we have a lot of things like Facebook groups, right? Where people with the condition talk to each other and kind of build a sort of camaraderie there too. What are your thoughts on these kind of like, I want to say like peer facing structures and groups versus maybe in addition to individualized?
I think peer groups online and other kinds of peer groups can be very helpful for people facing a common problem. They can also be helpful for the caregivers of those patients who have a whole set of issues. However, we found that for people with advanced cancer, groups don't work so well. People are highly distressed. People can't absorb the distress of other people when they're in that kind of state, and they need the privacy and the individual relationship to address the problems that they're facing. So we find that individual and couple-based therapy is the most acceptable and effective in this context.
I would love to hear more about the concept that you've been working on called double awareness. I think that would be really interesting for our audience. Can you go ahead and just give me just a overview of that?
Well, double awareness came out of our work with this concept, and I'll say a little bit about it, but it was partly to sort of modify, revise, and shift a prior way of thinking. We heard this morning, actually, David Kessler talked about Elizabeth Kubler-Ross, and she talked about the stages of grief. But what we found is that people with advanced cancer do not move sequentially through this. People move back and forth between facing the end of life, between hoping they're going to live for a very long time. And in fact, we think that optimal adjustment is actually not moving from protest and denial to acceptance, but actually holding this duality, the duality of facing the end of life, planning the end of life, and being engaged in life at the same time. And that duality is not easy to maintain for patients with cancer, because for one thing, it's very easy for patients to get swallowed up in the system of cancer care, and their whole life can become cancer treatment and living between scans with anxiety. We're trying to help people live their life at the same time, because people with advanced disease may be on treatment for the rest of their life. So there's no later time in which to live life. We want to help people maintain this duality. And we've actually created and validated a measure of double awareness, the double awareness scale. It has these two subscales of death contemplation and life engagement. And we think optimal adjustment involves being able to do both.